My name is Shireesha Dhanireddy. I'm in the Division of Allergy and Infectious Diseases, and it's my pleasure to moderate this session and introduce our speaker today, who is Dr. David Coleman. He is an expert in immunology and allergy. He graduated from the University of Michigan with a bachelor's in microbiology with distinction, and then received his medical degree at Wayne State with high distinction, and did his residency at Northwestern, and then moved out of the Midwest to go to Vanderbilt for his allergy and immunology training. And then we're very fortunate that he has joined the UW family last year. His expertise is in allergies with medications and vaccinations. So it is my pleasure to introduce him today. Thank you.
Hi, good afternoon, everybody. Thanks so much for that introduction. I'm so excited to have some time to chat with you about allergies and the COVID vaccines. And I've subtitled this talk, "What do we know and what don't we know?" And I think we all are understanding that this is a learning curve together that we are sort of understanding together. And so I'm hoping to chat in the next 30 minutes through my presentation about some common questions that I have received in the past couple of months regarding this topic. And then we'll get to your questions in the second half of the hour. All right. And I have no disclosures to report. And so I want to take a couple steps back and remind us of where we came from, where we started, because so much has happened in the past couple of months. So on Tuesday, December 8th of last year, that was the first day the UK vaccinated for COVID-19 with the Pfizer and BioNTech vaccine. On that day, 2 recipients of the vaccine experienced immediate anaphylaxis allergic reactions. Upon further questioning, they both carried an epinephrine autoinjector for reasons that were unrelated to the fact that they were receiving the vaccine that day. And so the director of the UK National Health Service, NHS, released the following the next day. As is common with new vaccines, the MHRA have advised on a precautionary basis that people with a significant history of allergic reactions do not receive this vaccine after 2 people with a history of significant allergic reactions responded adversely yesterday. And so that's sort of where we started. And so then the United States soon after started vaccinating for COVID-19. And we had, based on this knowledge that I'm sorry, did we lose that? Sorry about that. Sorry, I'm having technical difficulties here. Can you see it okay? Is it in presenter mode? Yeah, okay, good. All right, so based on the fact that they both carried an epinephrine autoinjector, we had to decide, as a country, how we were going to manage this. And so, we have looked and we have vaccinated millions and millions of people now. And luckily, I think if you've gotten your vaccine, you've been asked to sign up for VSafe, which is a function that the CDC is gathering reactions to the vaccines. And the last time the VSafe has presented the data was in roughly the middle of January. And at that time, roughly 21 million people, almost 22 million, had received the COVID vaccine. 12 million received the Pfizer, and just under 10 million had received Moderna, of which about 10% of those had at least checked in once with the VSafe function. And I mention this because I'm about to present VSafe data as later on in the talk as to side effect profile. And interestingly, 15,000 of those were reported to be pregnant. And so there was a question that has been asked of me as to, is there any new data on pregnancy and vaccination? And the answer is, they're starting to do the trials to better understand, to better conclude, the safety in pregnancy and lactation. But as of right now, all we have is that there have been this, a number of folks who are pregnant who have been reported to the vSafe data. And so let me talk to you about back to anaphylaxis now. The numbers that have been presented. So in this, out of the roughly 22 million people who have been vaccinated, roughly 71 of those had experienced anaphylaxis, 50 of which had received the Pfizer BioNTech, and 50 of which had received Moderna. And so interestingly, and I'm not quite sure what to make of this, roughly almost all of the patients who had experienced anaphylaxis were female. And so lately there has been curiosity among the allergy community as to why and if female gender influences in some way a propensity to experience anaphylaxis. Now, how many minutes did it take for most patients to experience anaphylaxis? Well, the median in both the Pfizer and Moderna vaccines was 10 minutes, which hopefully gives us a bit of a sigh of relief, as it is recommended that 15 minutes be the standard timing that people are watched. But however, there have been a couple that are longer, and I'll detail that more carefully in the next slide. And most patients had experienced the symptom onset in 30 minutes or less. Interestingly, in the 80% of which had a history of allergies or allergic reactions in the past, and about a quarter of which had experienced anaphylaxis in the past. So just like we had understood that these first two patients in the UK had an epinephrine autoinjector and thus had some sort of history of atopy, roughly 80 to 86% of folks had a history of allergies or allergic reactions in the past. And most of these reactions happened in dose number 1. And so here is the amount of time it took for symptom onset for these folks who had experienced anaphylaxis. And if you see here, most of them had experienced anaphylaxis by 15 minutes, and a great majority of whom had experienced anaphylaxis by 30 minutes. And so this will help us understand why the monitoring guidelines that we will talk about in a minute are the way they are. And so then let's talk about the numbers. So while anaphylaxis is a very concerning and potentially life-threatening thing, it's so far a very uncommon thing. It is present. It has happened, per last report by the CDC, in 71 individuals. However, the Pfizer BioNTech reporting rate is 5 per million, and the Moderna is 2.8 per million. And so it remains a very rare entity. Based on concerns about atopy and atopic conditions in their relationship to potentially cause anaphylaxis to the Pfizer vaccine, the CDC has put out a guidelines for triage of folks who have presented to get a COVID-19 vaccine and what we should do first. This slide is one of my favorite slides of the talk because it has really helped. A lot of us unpack, guidance and how we move forward in patients like this. And so I'm going to start from the right and move to the left. And so patients who have a history of who without an other contraindication or a precaution, so the other two columns, who have had an allergy to oral medications, even when there's an injectable version of that medication, or a history of other atopic conditions such as food, pet, insect, venom, environmental latex example, or even a family history of allergies. This is a proceed with vaccination. And so, if they've ever had anaphylaxis, they should have a 30-minute observation period. And then if it's a 15 minutes for everyone else. And so when you're thinking about folks who have had atopic conditions, such as these, you have to separate, have they had anaphylaxis? Have they not had anaphylaxis? Anaphylaxis is a 30-minute wait, everyone else is 15. Let's talk about those who have had a precaution to vaccination. So this has been challenging understanding this. Folks who have had an issue with an injectable medication that is immediate, the CDC says. Now, when I was in allergy fellowship, I learned that drug reactions should happen within an hour or two of receiving the drug if it's immediate, IgE mediated. However, the CDC is very clear that in the case of COVID vaccinations, the cutoff is 4 hours. And I think that's good. I think that catches more people. Some people have had issues with injectable medications or other vaccines, which are injectable. And what you need to ask yourself is it immediate? Is it 4 hours or less that the patient received onset? And if it is, that is a precaution to vaccination. What I have been doing with these patients is I've been doing a risk assessment. Do they need the vaccine? And most people are in a pandemic, and so yeah, they likely will need the vaccine. I usually do a risk-benefit discussion. The CDC says, for example, that you are a precaution to vaccination. There is a concern that potentially you may be at slightly increased risk for a severe allergic reaction. Most patients remain interested in continuing with getting a vaccine at that point, in my opinion, or in my experience. For all of these patients, a 30-minute observation should occur if they're vaccinated. There are people that the vaccine is contraindicated to. And those people are those who have had a severe allergic reaction, such as anaphylaxis, to a previous dose of the COVID vaccine, and folks who have had an immediate allergic reaction of any severity to any of its components, such as polyethylene glycol or polysorbates. And in those, the recommendation is not to vaccinate. So now's the point in the talk where I'm going to talk to you about Miralax. So you may wonder what a stool softener is doing in a vaccine talk. But actually, as time has gone on, this has been a really important medication to talk about. And it was at my fellowship in Vanderbilt where these first patients were described that you can actually get an IgE type mediated reaction to polyethylene glycol, or otherwise known as PEG 3350. And so this was a paper where they took a patient who was allergic to, who had multiple issues trying to get a colonoscopy. And every single time he tried a bowel prep, he had anaphylaxis. And this patient, they had done skin testing to polyethylene glycol, which was positive. And then they did skin testing to steroids, and that was positive too. So you may be wondering why we did steroids for polyethylene glycol. Well, polyethylene glycol and polysorbates are excipients in many medications, excipients meaning inactive ingredients. And so polyethylene glycol, for example, is in methylprednisolone acetate, but not methylprednisolone sodium succinate. And so in this paper, they showed that one was positive and one was not. Triamcinolone, Kenalog shot, that has polysorbate 80 in it. And so this patient ended up being positive to polysorbate 80 as well in the triamcinolone. And so I want you to take a look at the polyethylene glycol and polysorbate molecules, not for us to be molecular chemists, but to better understand that similar motifs are present in polyethylene glycol and polysorbate. Now, these patients are very rare and very newly described within the past 5 years, but the few patients who have been described have issues both with polyethylene glycol and polysorbate, presumably because these share similar chemical motifs. And so when the patients experienced anaphylaxis, experts in the field of allergy and immunology looked at the excipients in the Pfizer vaccine, and it's relatively clean. But one of the things that they noticed in terms of things that can cause anaphylaxis are that polyethylene glycol was in there. And so, and I don't want you to get too caught up on the 2000 part of it. The PEG, so Miralax is PEG 3350. This is PEG 2000. That just means the average molecular weight, because the motifs repeat. And so to the immune system, they look similar to, they look the same, because it's just how heavy the weight is. Okay, and then the Moderna vaccine was the same exact way, in that the Moderna vaccine also had polyethylene glycol 2000 in it. And so then the question is this the allergen? Well, it hasn't been clearly described that this is the allergen, but there's not when the allergists look through the excipients in both of these vaccines, this appears to be the most likely the most likely allergen. And it fits because we know that polysorbate and polyethylene glycol allergy is not a common allergy. And so the fact that we've only had 72 cases, 71, 70-ish cases, that potentially could be, that consistent. But it hasn't been well described. And so one of the questions that a lot of people had were, okay, there's PEG 2000 in both of these vaccines. What about the rest of them? Well, my slides are just a couple of days old, and that obviously Johnson & Johnson now is approved by EUA, but all of the rest of the vaccines that are currently in trial or studies, AstraZeneca, Johnson & Johnson, Novavax, and Sanofi, they have either polysorbate 80 or the Sanofi one has polysorbate 20, which again is just a molecular weight thing. So one thing to know, a lot of the lay public is really interested in egg allergy, and basically egg is not in the COVID vaccines, and so that's not an issue for the for the COVID vaccines. And then again, both Pfizer and Moderna both have this PEG 2000. And so I want to give you some tools when you're seeing patients and they're concerned about their previous medications, about what you can do to kind of convince yourself one way or another that this may be okay in terms of a PEG issue. And so I often ask patients if they've tolerated bowel preps or Miralax. Many patients have said they have done that. And I've also go to NIH Daily Med. And so here's a case that I'm going to present that I just kind of made up that helps, that will illustrate NIH Daily Med, which is a great resource. So this is a 36-year-old female with an inflammatory bowel disease who 1 year ago has had wheezing, low blood pressure, and hives around the time of receiving adalimumab. And so basically what you can do is you can go to the NIH Daily Med website and dial in whatever medication that you're interested in. And so in this case, we're interested in Humira, otherwise known as adalimumab. And when you scroll down, you can actually go to ingredients and appearance. And so if you notice here, polysorbate 80 on the right side is in the inactive ingredients, So I personally use NIH Daily Med for a lot of consults. I have questions about whether dyes are an issue, and so I can see what dyes are in the medications. And so, when you are concerned about whether the patient has tolerated PEG or polysorbates, or maybe has not, you can use NIH Daily Med and look at the inactive ingredients to better understand what is in the inactive side of the medications your patients are taking or have tolerated or have had issues with. And so in this case, does the patient have a polysorbate 80 problem? Unclear. More testing is needed, but it's now on the differential. And so, now we go back in this patient to the triage. And so you're wondering if this patient is contraindicated or as a precaution? Because you have identified that on the differential diagnosis, the patient may have had an issue with polysorbate 80 in the case of this Humira issue. On the other hand, they may have a precaution to vaccination because it's clearly an immediate reaction to an injectable medication. So how do we proceed in this patient? So the CDC has noted that polysorbate and PEG are excipients in many vaccines, injectable therapies, and other products. Patients with a known allergy to PEG or polysorbate or an other mRNA vaccine component are contraindicated. Persons with a reaction to a vaccine or injectable therapy that contains multiple components, one of which is PEG, an excipient, or polysorbate, have a precaution to vaccination. And so I thought that was really fascinating, and that the CDC has recommended that if you don't know, but it's on the differential, that's a precaution to vaccination. So that, again, that patient should have a risk-benefit discussion with you. And if they decide to move forward with the vaccination, a 30-minute window should be, monitoring window should be selected. So let's talk a little bit about side effects. A lot of questions came up about side effects. And so the CDC has not released what's going on with Moderna dose 2, but they have released Pfizer dose 1, Pfizer dose 2, and Moderna dose 1. And I would say that, you know, the absolute numbers of side effects are slightly higher with Moderna, but they look fairly similar to me. So, you know, in dose 1, quite a bit of pain, presumably injection site pain, and, you know, fatigue, headache, myalgias. Those are fairly common, about 20 to 30%. And then a lesser amount have chills and fever and swelling or joint pain and nausea. But those are the most common side effects of the vaccine. If you notice dose 2, comparing that to dose 1, that sort of helps verify what we sort of know to be true, is that dose 2 definitely is a little bit more of a upkick in the immune system, and thus a lot of these side effects are much more common in dose 2. And I imagine that would be the same for Moderna dose 2, and hopefully that data will come out soon. So let me talk to you about another case, and then we're about halfway done with our talk, and I'll open it up to questions, okay? So a patient presents with you with concern for an allergic reaction to vaccine. They received Moderna COVID vaccine 1 week ago. They did well in the first 15 minutes. They had arm pain and a mild headache in the first few days, now resolved. And about a week into the course, developed a red arm at the injection sites. And so this, I've had so many consults on this question so far. So, you know, breaking it down, I think about, you know, anaphylaxis. It's like, you know, usually an immediate. The CD says in the first 4 hours. So they did well in the first 15 minutes, and they didn't have anything in the first 4 hours. So maybe an IgE-mediated reaction this patient doesn't appear to have had that. And then they had arm pain and a mild headache in the first few days. I think we all are pretty comfortable now that that's a pretty common side effect of the vaccine. And then about a week into the course, developed a red arm. And these are representative pictures of that are not my own patient pictures, but of patient, you know, that are similar to pictures that I have gotten in the past. And so, you know, the question is, what is this? This is pretty common. This is a delayed reaction. The data is still out about whether this is an allergic reaction or you know, just maybe your immune system just revving up. My gestalt is that it's probably the latter. So what do we do with this? Interestingly, this usually comes on about a week after the vaccine is administered for the first dose. And if it's going to happen the second dose, it comes on a couple of days earlier, usually. At least that's been my experience. And so sometimes it's itchy, rarely it's painful. The patient generally doesn't have systemic side effects. You know, they don't have fever during this. Initially, when this first came out, what people were wondering whether this was cellulitis. This is the CDC is pretty clear on this one, that a delayed onset local reaction around the injection site in patients who otherwise don't have a contraindication should receive the second dose. And the second dose, I've got a lot of questions about whether you pre-medicate or post-medicate. Well, there's not a lot of good data, but the expert opinion suggests that you should try not to pre-medicate if especially with NSAIDs, but post-medication with antihistamines, because usually it's itchy, is okay. That's expert opinion. That's not based on much data. So that's basically it. Those were the most common things I brought up, but I know there's many questions that I didn't discuss that I will do my very best to try to answer in the next half hour.
Thank you so much, David. And thank you all for sending in questions ahead of time for us to review and go over. I do want to bring up a couple of things that came up in the Q&A, David, regarding patients who had suspected anaphylaxis that was reported through VAERS, those 71 patients, and if there's any workup being done, further testing of patients who have suspected anaphylaxis or confirmed anaphylaxis to determine anything more about them in terms of that particular allergy.
Yeah, and before I answer that, I just realized that my presentation, unfortunately, was in a not very aesthetically pleasing view the whole time, and I'm so very sorry about that. I would be happy to, just please email me and I'll send you the slides if in the future. But so I would say that we are starting to do skin testing that is similar to the patient that was performed at Vanderbilt, where we are doing prick testing to polyethylene glycol, and then prick testing as well as intradermal to steroids, understanding that we're more focused on the excipients of those steroids than on that themselves. Patients that have had immediate reactions to the COVID vaccine, we'd be very happy to see in our clinic to perform such testing.
Great. And then there was a question specifically about tryptase being measured. So if you can comment on that.
Yeah, so mast cells are like little grenades in our body, and when we come in contact with things that they don't like, they just burst and release a lot of chemicals. Tryptase is one of the chemicals that mast cells release, and it's fairly specific to mast cells themselves, and so is oftentimes caught in allergic reactions. If in patients who you are seeing that in the emergency room, for example, who have had questionable or concerning allergic reactions, I would be very thankful for you to have to draw a tryptase. The kicker is that the tryptase has a low half-life, and so it really needs to be drawn within 4 hours of the reaction itself.
Great, thank you. And I know within UW Medicine, David, you've been working on a protocol for people in the emergency room setting who are presenting with a potential anaphylaxis to have that drawn, as well as some additional labs. So if people are referred to the EDs in our institution, we do have a protocol for that that's going into place. There's some questions about this delayed reaction. So a few questions about the 4-hour cutoff, but then also if people have evidence of more severe reactions that could be consistent with anaphylaxis that are even more delayed, and how you would advise about second vaccine dose in those situations.
That's great. I think that 4 hours was the CDC's official recommendation. Hopefully you may have noted that 20 hours was reported as one of the more the latest, the most delayed of anaphylaxis that was reported in the first data. And so I think that any patient that you are concerned for an IgE-mediated reaction, you would be very happy to send them to allergy clinic, and we can better discuss. We're starting, expert opinion in allergy is trying to really figure out what to do with different buckets of reactions. And based on the reaction, we can consider a second dose, or if the symptoms are pretty concerning, we would probably recommend referral.
Great. Yeah, there were a few questions about people proceeding with the second dose, even if it's not an anaphylaxis reaction. For instance, if you had a delayed reaction, even the one on the arm that you showed, the delayed Moderna reaction, should they be counseled to get it in the opposite arm this time? Would there be any precautions?
I don't believe there's any reason to do it in the contralateral arm. I don't know if there's any data on that, but I think that the patient should receive the vaccine in the usual fashion without pre-meds, and can post-med with antihistamines if it's itchy.
Great. There's another question about if someone had severe reaction, even if it's not anaphylaxis to the first dose, and refuses the second dose, how would you counsel them about that refusal? As currently the recommendations on the US is to complete both doses if it's Pfizer or Moderna.
Yeah, that's a good question. I think just like anything else in medicine, a risk-benefit discussion should be performed. As you mentioned, it is currently recommended to complete the program, which is at this moment 2 doses with Pfizer and Moderna. But adults are adults, and I think you just have to counsel on the risks and benefits.
Great. And then some people had a question about, you touched upon this a little bit, about pre-medication prior to vaccination. People are pretty concerned about the high numbers of systemic reactions with that second dose in particular. Some of you have received the vaccine and had a headache and chills the first time around that were pretty severe, and then hearing news that the second dose may be even a higher risk of these symptoms. People want to potentially pre-medicate. So how would you counsel about that?
I would counsel that, while there's not a lot of data out there, there is concern that pre-medicating, and this is actually what I counseled to my father because he wanted to do the very same thing. I would counsel that while there is not a lot of data out there, there's concern that pre-medicating may, especially with NSAIDs, may reduce your body's immunogenic drive to do what it's supposed to do with the vaccine. So I would recommend I would not recommend, based on expert opinion, I would not recommend pre-medication, and post-medication only if you need it. Great,
thank you. What do we know about the side effects in children so far? We know that currently the Pfizer, Moderna, and J&J that was just received EUA, as you mentioned, are really only in 16 or 18 and over. Actually, the Pfizer is the only one that's for 16 plus. The other 2 are for 18 plus. But do we have any information about allergy or side effect profiles in children receiving vaccines?
The short answer is that we don't right now, no. Yeah.
Okay, great. Well, hopefully we'll have more information as we get more study data on that. And then somebody put in the question about the concern for muscle or nerve damage reported in people receiving vaccines. Has that been a significant concern?
I have not seen that there is any data suggesting that there's any extra concern with the COVID vaccines in this particular issue. I know that there's a theoretical risk of damage to surrounding tissues with any vaccine.
Great. There's a question about someone who has had prior autoimmune disease or history of autoimmune issues. Are there any precautions for that population for getting either of these vaccines or the 3 vaccines that are now available?
Yeah, I think that there's not any particular guidance as to anything specific that they should do differently. I know that there are studies ongoing to better characterize the immune response in folks who, for example, like my first case, maybe are on something like adalimumab, but at this point, I don't think there's any specific precautions that that is recommended to take.
Great. Someone asked about alcohol consumption, whether that drinking alcohol around the time of vaccine affects immune response to the vaccine.
Yeah, I looked at this over the weekend and I couldn't find anything specifically. I imagine, I don't think there's any specific data on this, no.
Great. So we know that other vaccines have been reported to have potential adverse effects like Guillain-Barré, for instance, with influenza vaccine. How can you comment on advising patients who have a history of Guillain-Barré or other reactions to other vaccines in the past, and how you would counsel them for COVID-19 vaccination?
Don't quote me on this, but I believe the Guillain-Barré Society has recommended to continue on with the vaccine just like anyone else. And so I would direct patients to the specific society, as many of them have brought out their own guidance as to how to proceed with the vaccine, because everyone has questions with lots of complex medical issues, including those.
Yeah, one other serious side effect that's been reported, and even in the New York Times, has been, and we briefly touched upon this, David, before, was the thrombocytopenia. So people, there have been these rare reports of people developing critically low platelets post-vaccination, and commenting on any precautions for people who have a history of low platelets in terms of getting this vaccination.
Yeah, I read about those reports as well. I know there was a sort of a very unfortunately famous one in the New York Times about a physician who passed away. I would be interested to meet with our hematology and hematology colleagues to better understand what their thoughts are, but I don't want to comment specifically on that, but I would be interested to hear from hematology folks, if there are any in the audience, about what their thoughts are.
Great. The other question, similar to the Guillain-Barré, is just Bell's palsy was another potential adverse event that occurred in the clinical trials, and I know it was deemed not necessarily related to the vaccine, but people with a history of Bell's palsy are concerned about whether they should get the vaccine or not. So what would be your advice to them?
I would say that I would say that the likelihood of getting Bell's palsy is low, but I would probably direct them to their neurologist. But I guess what I'm not so, the data that's not so clear on is whether getting Bell's palsy from one thing predisposes you to Bell's palsy from another thing. But likely a risk-benefit discussion would be appropriate at that point.
Great. One other question that's come up that's an interesting potential adverse event is chronic urticaria. Someone notes that they've seen a case of chronic urticaria that's persisted weeks, 4 weeks, even post-vaccination. So have you heard any of these reports of chronic urticaria?
I have heard of a couple of reports, and this has really made me think about, what causes urticaria, and whether it's due to an allergy to the vaccine component, or more just the immune system getting revved up, and then it just sort of creates urticaria. But I have not. 4 weeks would be the longest I've heard of an issue happening like this. What I want to stress to the audience is that the mainstay for urticaria is antihistamines. And so often it takes more than the over-the-counter dosage of antihistamines to treat urticaria. And so, I would try that first before doing steroid courses.
Great. Something that's come up that's more operational is for our UW community, if we're trying to, patients are trying to schedule or employees are trying to schedule who have a history of anaphylaxis to any injectable medication or vaccination, there was a hard stop for being able to schedule. That hard stop has been removed, and Dr. Coleman and others have been working on the process for that. As he mentioned, there's that yellow category of precaution, and we want to make sure that people understand the risks and benefits. And so it's not a hard stop anymore. You can still schedule, but you just need to have a letter, and that can be an EPIC that can that says that you've discussed it and you've agreed to continue with vaccination, and there will be a prompt in the appointment for the scheduling that says 30-minute, that you wait for 30 minutes, or not necessarily prompt, but when you're doing your pre-screening questions, it would come up, you would give your medical clearance letter and you would wait for 30 minutes rather than 15 minutes. So it's no longer a hard stop anymore if you have a history of anaphylaxis. So thank you, Paul Pottinger, for asking that question. There are actually still a number of questions about NSAIDs and acetaminophen and timing. And so just to have some clarification about that, as people are really wanting to give the right advice to their patients about post-medication. So if they do take it post, because they need to, would you recommend a period of time that they not take it after vaccination and wait until they take the NSAIDs or acetaminophen?
I would say that that data is not very clear on that, but as long as a syringe has left the arm, I think you just say go ahead. I think, look, taking a step back, I imagine many people in the trial, felt the same way we all did when we got our second vaccine, and probably took something like an NSAID or a Tylenol, but and it's still very effective. And that's just me editorializing. The official answer is that there's not a lot of guidance, but as long as they've already received the vaccine, it's okay.
Great, thank you. I think we went through most of the questions that people sent in online. In terms of people did have some questions about adverse events with the J&J vaccine. If you know of any newer data that was just presented to the FDA, if there's a signal for anything different than we're seeing with Pfizer and Moderna, or any notable adverse effects that we should know.
I need to review it a little more carefully, but what I do know is that that there was, I didn't hear of a signal for anaphylaxis. Now, there wasn't a signal for anaphylaxis before the other ones came out, and so time will really tell. I do hear that it's pretty immunogenic, however, and patients with their single dose do not feel, they sort of feel similarly to how most of us felt after our second dose. So, yeah.
Great. There were some questions that are a little bit out of the scope of the allergy question, but people wanting to know if how this vaccine does against asymptomatic spread of infection. And so I do want to say that there's more and more data coming out regarding efficacy of vaccine for preventing asymptomatic spread. And we are also getting more data about even one dose of Pfizer and Moderna, as I mentioned before, being fairly effective in data from the UK and Israel, although time will tell in terms of the duration of protection, which is why the US is still currently recommending 2 doses. And I think those were most of the questions. David, did you have any other that came to the top of your head?
Yeah, we have a question on the Q&A chat about what do we know about the J&J vaccine and excipients for persons who have had a past history of anaphylaxis or allergic reaction to PEG. And so that sort of goes back to what I discussed earlier, is that PEG allergy is a really rare entity. So in the few patients that we have found with PEG allergy, they were also allergenically cross-reactive with polysorbates. Polysorbate 80 is in the J&J vaccine. And so if I were seeing a patient who had anaphylaxis to PEG, I would have to perform more testing, but I would definitely would not say just go ahead and get it. I would have to perform more testing to see if they mimicked what we know in these few patients to have this like cross-reactivity issue.
Great, and as you mentioned, you know, much of that, what we know is after the vaccine was already being given on a wide scale, and so as we get that J&J vaccine this week and in the coming weeks, and millions of people will get it, we'll see if there's more of a signal with that. The same person is asking a question specifically about the NSAIDs and why would it be expected to blunt cell-mediated immune response, specifically in terms of the just decreasing the immune response of the vaccine?
Yeah, that's a good question. And I think that the answer is that there was a small paper that suggested that if you pre-medicated with NSAIDs, and it's a fairly old paper. I'll try to find it and pass it along to the particular panelists that asked the question. But I think a lot of this may be just wives, things that we all think that may not be, it's hard to know because there's no data. And so I hope I inarticulately answered your question.
Thank you. I think those are most of the questions that have come in, and the ones that we also, we went through pretty much all of the ones that people submitted as well, either in the PowerPoint or in the post Q&A discussion. So unless there are any other comments or questions in the Q&A, then I think we'd all like to thank you for your time today. And as David mentioned, he's happy to share the PDF of the PowerPoint with, and we can get that posted as well with the talk online. Thank you so much for your time.